is a definite BKV incidence was higher in this patient group, whereas CME infection and varicella infection was definitely on the lower side. And the trend of serum creatinine was almost similar with both the groups. So, yeah. Can we go for the second poll, please? Dr. Kaushal?
Yes, sir. Yes, Lord.
So here I want to just postulate what is the optimal dose of Graflon across different patient groups. Standard fixed dosing for all patients, 6 milligram. Higher dose in higher risk patients, 7 to 9 milligram. Or lower dose, 4 to 6 milligram in patients. You can end the poll. Hello?
Yes, sir. Yeah, the 47% of people have gone with standard fixed dosing for all patients. So whatever is in the catalog, the recommended dose of 6 milligram per kilogram is what most of the people are using. With about 32% of people going for a lower dose, about 4 to 6, and 21% using higher dose. So most of them are agreeing to use the conventional 6 milligram per kilogram.
So, yeah. So coming to the poll, so there are many studies which have done low dose ATLG also, which they have clearly proven that low dose ATLG have been effectively used as induction agent. So this is a study by Kamal Kiran. It's a retrospective study which kidney transplant patients who underwent from 2020 to 2024. And the patient has been followed up for 12 months, just like in other cases. Here, the number of patients were 190 patients, and the average dose used was 4.14, plus or minus 1.4 milligram per kg. And the average cumulative dose, like I mentioned earlier, it was we were talking about 400, 350s. Now it is well below 350. It's around 250s, 268 plus or minus 89 milligram, and they had a very good outcome. So they had rejection episode. Definitely, they had rejection episode. ACR was 12 patients, 6.31 patients, and ABMR of 4 patients, which is around 2.1 patients. So they have effectively shown that a low dose ATLG is effective in preventing rejection in kidney transplantation. But let me mention this: the study group which they have mentioned, they have taken, is all low risk profile groups. So definitely that might be a cause that they have got a very good result in this study. And there is another study from JP Hospital, Noida, single center retrospective study analyzed data from kidney transplant patients between 2017 and 2024. They have had a head-on comparison with thymoglobulin. So number of patients in the Graflon group is 206 and thymoglobulin group is 375. And the Graflon group, the average total dose used is around 5.4, whereas in thymoglobulin, they have used around 2.37. That's also on the lower side. And the transplant outcomes, rejections, 24 patients in the Graflon group and 37 patients in the thymoglobulin group. Out of which, 20 in the Graflon group, 20 cellular rejection, 1 combined, 1 ABMR, and whereas in the thymoglobulin group, 26 acute cellular rejection, ABMR, and 9 chronic ABMR patients also have been noted. And here again, one more point, the short-term and the long-term outcomes of kidney transplant recipients receiving thymoglobulin or Graflon was similar in terms of graft rejection incidence. However, thymoglobulin was associated with a higher risk occurrence of de novo disease. And again, I really don't understand the importance of that actually. Thymoglobulin was associated with a higher occurrence of de novo disease. And they haven't mentioned the details of the de novo disease, like, if it is like, diabetic or like, IgNF disease or FSGS or whatever it is. So here also the low dose ATLG has worked beautifully. And this is, now I'm just going to briefly mention about head-on comparison with ATLG versus ATG, which we have already mentioned a few more studies which I just want to show. So this is a study by Sharma, Tukral and et al. Single center study, Rabindranath Tagore International Institute of Cardiac Science, Kolkata, 2019 to 2020. 62 ABO compatible renal transplant recipients were included in the study. They were divided two groups of 31 each. Thymoglobulin 3 mg per kg and Graflon 6 mg per kg. All patients were followed up for 12 months and the two groups were compared for incidence of rejection, infections, graft function, and patient survival and graft survival. So, here we can clearly see there was no significant difference between the ATG and the ATLG group. There were two rejections in the thymoglobulin group, 6.4% and 3 in the Graflon group. All were comparable. And so they have concluded that at an average dose of 6 mg per kg ATLG is equivalent to thymo in terms of outcomes with possibility of better immune reconstitution at the end of 12 months. So here they have clearly shown the absolute lymphocyte count at the 7 days versus 1 month compared with 1 month and 12 months. So here we can clearly see with Graflon, the absolute lymphocyte count has definitely peaked actually. So that's why the rates of infections have come down. The innate immune system has regained the efficiency. Here initially it was comparable and at the end of 1 month also more or less comparable, but at the end of 12 months, the absolute lymphocyte count in the Graflon group has peaked actually. And this is another study where they have studied about head-on comparison with ATG versus ATLG. And we have more or less a similar data. And here the amount of ATLG used is on the lower side. ATLG is 4 mg per kg single dose. And most of the results were 1 year graft survival was more in ATLG group. And death sensor graft survival was similar. Bacterial infections and sepsis-related mortality was significantly higher in the ATG group as compared with ATLG. Probability of infection occurrence was more in ATG. ATG, when used as an induction agent, has significantly reduced bacterial infection, sepsis-related mortality, and improved graft survival as compared to ATG. However, biopsy-proven active rejections, death sensor graft survival, and viral and fungal infections were almost comparable. And this is another study, multiple studies have been there, and just briefly going through it. Here also, the patient survival in the Graflon group and the thymoglobulin group was 99% versus 98.8%, which was almost similar. Reports have been similar efficacy has been denoted. And there has been a head-on comparison with basiliximab also. And there also at the end of 1 year survival, it's a very small study where the number of patients in the Graflon group was around 23 and Famlet was 12 patients, and the standard protocols, everything has been followed. So at the end of 1 year of kidney transplantation, all grafts in both groups were functional with no mortality and very minimal infection rates. So Dr. Kaushal, can you run the third poll, please? Dr. Kaushal?
Yes, sir. Yes. Done.
So your choice in ABO incompatible or highly sensitized patients. So would you go for ATLG, ATG, low dose ATLG or high dose ATLG? Please mention.
Maybe we can share the poll results.
Yeah, a few more to, yeah, okay.
So it's the standard ATG dose, which most of them are preferring in spite of a highly sensitized or maybe incompatible transplant patients. But 50% agreeing for a standard dose of ATG, Dr. Jaiju. And maybe Dr. Jaiju, it's 9:34 maybe, and now we can probably rush.
Yeah, we are quickly, quickly.
Well, we get time to discuss. Thank you.
Yeah. Yeah, so coming to your preference in highly sensitized patients or ABO incompatible transplant, we have few studies which have clearly mentioned about the usage of ATLG in ABO incompatible transplant. The studies come from Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. Even though the patient population was very less in the study group, they have a very good results actually. The number of patients in the Graflon group was 14 and thymoglobulin was 14. dosage was comparable with whatever we have mentioned, and the creatinine follow-up and the rejection rates and everything was similar. The graph on the patient survival at the end of 1 year was almost similar in both groups. So thymoglobulin and Graflon in doses of 3 and 6 milligram per kg respectively were comparable in almost all the means in both groups, ATLG as well as ATG. And there is another KI report which is from a publication which has come in KI reports. Use of Graflon and thymoglobulin as in ABO incompatible transplant recipient with the anti-HLA sensitization. Single center study, and for maintenance, almost 28 patients were used, and almost similar results. We have good results shown in the usage, ABO incompatible transplants also. However, I haven't used Graflon in ABO incompatible patients. And now I just want to briefly mention about ALC-based dosing. We are almost close to the end of the talk. So there are a few studies which, they have done optimize the dosage of ATLG by absolute lymphocyte count. So this is one study which has been published in ISOP recently. So the study has been done to evaluate the use of absolute lymphocyte count as a simple bedside marker for determining the dosage of ATG in kidney transplant recipients. So it was a prospective study done over 12 months. 42 patients were taken into consideration. So all patients received an initial dosage of 1 mg per kg on the day of transplant, and subsequent doses were based on ALC with a cutoff ALC of 500 cells per microliter was kept. ALC was monitored until stable graft function was achieved, less than serum creatinine less than 1.2. All patients were on standard immunosuppressive regimen, and the patient was followed up monthly for 6 months post discharge. And so coming to the conclusion, ALC is practically the dosage group based on ALC group. 16 patients received 2 milligram per kg, whereas 26 patients received 3 milligram per kg, and no significant difference in acute or chronic registers were noted between the groups. So they have concluded that ALC is a practical and cost-effective bedside tool for adjusting the ATG dose in kidney transplant recipients. Lower ATG dose based on ALC may reduce infection rate, risk, and overall transplant cost. So this is the poster which they presented in ISOP. So here they have shown that cost reduction, they were able to bring in a cost reduction and dose reduction of almost 22% when they have taken absolute lymphocyte count based dosing for the injection agent. So should ALC-based dosing be adopted as a standard practice to reduce exposure to injection agents in India? So that's a poll, last and final poll. Kaushal, please run the poll.
It is less.
It's almost 10:40, so we can end the poll.
So most of the participants feel that an ALC-based dosing should be adopted as a standard practice in Indian transplant centers, and that can probably reduce the cost and drug exposure.
Yeah. So what are we positioning Graflon in current scenario? We have understood that efficacy is comparable to ATG or even Basilista at a standard dose of 6 milligram per dose. Selective depletion, faster immune reconstitution, fewer bacterial infections are the major advantages, and this is definitely cost effective. If we can use the ALC-based dosing reduces drug cost by almost 20%. And flexibility, effective across standard risk, high risk, and ABO incompatible transplant. Consistency, which we have already mentioned. So the current practices: low to moderate immunological risk, 6 milligram per kg dose of Graflon. High immunological risk, 9 milligram per kg. And there is still a debate going on whether it should be given as a single dose or a divided dose. I follow divided dose. That question is open for discussion with the expert panel. And Graflon can be given pre, intra, as well as post-transplant according to the patient's condition and the clinician's choice. So overall, ATG is a useful addition to the induction armamentarium in the Indian setting. Thank you.